our next segment, and I am so excited to go ahead and show some of our RheumyRounds talk show clips. So RheumyRounds is a segment on our talk show where we have rheumatologists come to and sit at the table with patients and have a conversation about things that affect both patients and rheumatologists, and basically have a conversation more informally than you would at a doctor's office, and just being for patients to see the rheumatologist's perspective and for rheumatologists to get an inside look on the patient's perspective. So I am going to go ahead and start playing those clips. I believe that we're getting better on time. Let's see, 11:06. And I was supposed to start to play these at 10:45. Okay, so I will go ahead and start playing these. And yeah, if you have any comments, questions, or anything, please feel free to put it in the chat. I am here at the chat answering any questions that you may have. So please let me know and I will be happy to share. Alrighty, gonna go ahead and click this again.
I agree that nonverbal communication is like 90% of the message. My one reservation is that sometimes there isn't an autoimmune condition.
Yeah.
And there are a lot of other mental health conditions that can cause very similar symptoms. And so when we offer our opinion, many times, not always, but sometimes patients are very disappointed with that. And I can package it as empathically as possible, but like you said, Tiffany, like they're coming in and they want the diagnosis that they know has a treatment for it that's easy, right?
Yeah.
Like I have rheumatoid arthritis, you're going to give me something and it's going to turn this around in a couple of weeks or months. And that's not always the case. And so from the physician perspective, it helps when patients are open to the message, especially if we're the fifth rheumatologist and we're saying the same thing.
That's a good point.
Like,
That's a good point.
So, because we're not there to crush your hopes or ruin your dreams, we're there to partner with you and offer you our opinion and our interpretation of the art appreciation data, right? And it's hard for us too to sometimes have these conversations because we want there to be all tied up in a nice little bow, a diagnosis and a simple, straightforward treatment, but that's not reality. That's not the life in which we live. And so I think that that's an important part of this conversation as well, not just the physician being empathic and receiving and listening, but that goes both ways. Patients need to also be receptive and hear what it is that we're trying to say, rather than kind of interpreting it in a different way.
That's a really, really great point, actually. And I'm glad that you and see that's exactly the beauty of the show, RheumyRounds, and why we do this, because who's going to talk about this in an actual doctor setting? And right. I feel like that makes a lot of sense. And as a patient organization, we do get a lot of patients that come in and feel very disappointed. And I think that's also why many of us, when we finally get a diagnosis, we feel relieved. There's this sense of almost happiness. And so that's a very good point. Thanks for bringing that up. Carrie, sorry, go ahead.
I was just going to say, just like kind of brainstorming, I wonder if there's some way for patients who are new to this journey to help them maybe reframe that sense of like relief or satisfaction with a visit, more so on, was I listened to, was I heard, rather than did I get the answer that I was looking for? Because sometimes, Carrie's a great example. It took 8 years to figure out the right answers, and it can take a lot of time. And if that's the end goal, it can maybe be dissatisfying, as opposed to, have I found a partner that will at least walk on this journey with me?
Yeah, and I think So two things that I think to kind of pinpoint, to piggyback on that. One word that I heard you say a few times is that you're partnering with your patients, and that is something that I think is, sadly, in my personal experience, I would say rare, um, but really, really important. That it's not a matter of, we come to you, you tell us what to do, we do as you say, end of story. But it's a matter of, we're going to talk this out, and we're going to try and do the best we can to figure out what might be causing any of the things, what we're looking for out of this visit, and what is our best path forward. And I think that's really important. And like you said, there, the other thing I wanted to kind of point out is, you said, uh, I mean, we all kind of know that this isn't always an easy, and there's not always an answer. It might not be an autoimmune disease. It might not be, something that we can look at and say, here, X, Y, Z. And while that is what we're looking for, obviously, is an answer and a solution, when that's not there, it's coming back to that inflection and that communication. It's, if I come in and I say, look, I'm sure I have rheumatoid arthritis, this is the treatment I should have, here's why I think so, and you just say no, that, then we're going to have, a problem. I'm going to come away from that feeling very negatively about that experience. But if you explain what it is you're seeing, what it is that you would be looking for that would lead you down that direction, it's really just, the more information that you could offer, in both in terms of what you're seeing and in terms of what you're not seeing, that helps us to say, okay, where do we go? Where does that leave us, and what do we do next? And if I could just add in that one other point, I think is so important, is that what do I do next, or where do we go from here? Because one issue I've had with a lot of doctors, and sadly I know a lot of other people who have as well, is we come into the doctor and we say, I have XYZ symptoms, and they say, oh, okay, so we will do ABC tests. And then they call us up and they say, great news, A, B, and C were all negative. You don't have that. Have a nice day. And then we're stuck. Because, okay, it might be good to know that we don't have those particular conditions. Those might have been scary, and it might be, a relief to know it's not that. But we're not done. We're still sitting here with those same issues that we came in with. And if the doctor is done and thinks that's the end of the conversation, it just kind of leaves us hanging. And so having that, here's why, and here's what we can think about now, here's what we can look at now, here's some other things that we can kind of monitor for.
Did you want to respond to that, Lisa?
Yeah,
I have something
I didn't
to
know
add.
if, I saw you writing. I didn't know if there was another question coming. So I think that's a great point. And I think, from, I'm probably guilty of that myself sometimes, because in our mind, like we're always worried about ruling out or making sure that it's not either a complication of an autoimmune or autoinflammatory condition from medication, something new. And then when all that comes up negative, then what do we do? And usually then it gets to the point of, we don't know the answer. I don't know why you have it. Good news, all the scary stuff was negative and it wasn't that. And so I think also that probably, and this is an excuse and not a good reason, but it probably also just comes from trying to be efficient and lack of time, and closing the loop and circling back. And so if that ever, I try, when in those situations, when I give the results, I try to say, are you still having whatever symptom it was? or give advice like, what I worked up was negative. I recommend you follow up with your primary care physician because I don't think this is related to your autoimmune disease. But if that doesn't happen, I really do hope that my patients reach out and are like, okay, Dr. Zicker, hey, remember what are we going to do next? Because it may have been just that I missed on a detail. But that's a really, really excellent point. And I don't think anyone's intentionally trying to leave you hanging. And I definitely wouldn't want to do that. And so it's something that I can work towards being better at.
I think that in a lot of cases, people like myself, for example, I have never had a positive lab in my life, ever. Everybody tells me you have perfect blood work. And that is a challenge. We hear that so often. And it's got to be just frustrating too, as a doctor. You obviously want to give answers and you're running all of the tests. And that leads back to this whole, the patient feeling like no one believes me because I'm feeling this, but no test is detecting anything that's happening to me. And so I circled a big word that kind of summarized, I think, what you were both talking about. And that's really information sharing. And there's so many contexts that fall under that. And I think when we're thinking about times that we've had good experiences with the rheumatologist in the office, it often revolves around good information sharing. The doctor is providing us with explanations, like Carrie said, okay, this is why I might not think it is this, or this is something maybe you should go learn a little bit more about. This could help you. So good information sharing. And I think at the same respect, when you don't have good information sharing and you're left with a lot of questions or the time and there's not follow-up between the portal or whatever that is, that lack of information sharing, I think, can be extremely detrimental and can really shape that what is good and what is perceived as bad.
And if I can just add one thing, kind of flipping on the other side, I think we as patients need to take a little bit of responsibility for that ourselves too. Just as an example, my mom growing up, my mom, my grandmother, anybody, like people, they got sick, they went to the doctor, they got this medication. That's all there was to it. And if I was asking my mom, what happened, what did they say about this, and what do you need to look out for, and do they think it could be related to that? The answer was very often, I don't know, because if the doctor wasn't offering that explanation, she wasn't asking for it. And, years ago, I also wasn't asking for it. So I've had, some medical issues in a different area that I now wonder if, how much was the stuff I was dealing with in college, how much is that related to the other issue that I had when I was 30? And I don't really know because I didn't ask questions back then. So there's all that information that I don't have and can't get from 20 something years ago. But, it's because I didn't think to ask. I didn't realize how important it was for me to ask questions, for me to try and find out and learn all I could about whatever it was that I was dealing with in my body. And so I think absolutely we want our doctors to offer as much information as they can. But I think we also need to take it upon ourselves to make sure we ask the questions that are weighing on our minds. If they say, here, I want you to take this medication, ask about it. What is it going to do for me? What is it going to do to me? What side effects should I look out for? Anything. We have to remember, if we want them to think of us as partners and working together to come up with solutions, that means it's also partly on us to come up with the questions too.
I think that's great because it helps a lot. From a physician perspective, there's so much I can tell you, right? I can just cite the doctor version of Wikipedia, and for some people, I'm going to lose them if I do that. And so it helps us so much when you come with specific questions. so that we can give you the information that you specifically are looking for. I think the other part of that is sometimes these conversations are just best done in person or in a visit setting. And so oftentimes when I have patients that have lots of questions, that's what I do. I'm like, let's schedule an appointment so that we can talk about all of this, because then you have my undivided attention, and it's so much easier to check for understanding and like do the back and forth with clarifying questions and all that in person or over the phone than it is in a portal or trying to write it all out. And it gets complicated. And so that's the other thing that my practice is, and that I hope that my patients have actually like started to adopt. They're just like, I made an appointment because I have all these questions. Like, yes, perfect. And I think that is, it's just a really great way of simplifying and streamlining and making sure that you get the information you need and when you need it.
The condensed version of my sort of story leading up to that is I was experiencing a myriad of symptoms that just never seemed to make sense. I was getting dizzy, I was having joint pain, I was having muscle aches, all kinds of things, starting back in 2007. And the beginning of 2008, I decided, okay, something is wrong here. I need to start, I need to see a doctor. I need to find out what's going on. And I spent 4 years going from doctor to doctor to doctor, with them completely dismissing me because although I said, a laundry list of symptoms, they said I looked fine. And the tests that they ran didn't really show much. And they just kind of left it at that. And I was just stuck. And then after that, I developed some new symptoms that were actually more visible, some joint swelling and rashes that they could no longer tell me, hey, this is just in your head, maybe you're just depressed. I think that's one of the things so many of us have heard so often. And it seems to be what doctors will say, what many doctors, I don't want to say all of them, but what many doctors have said when they don't see an answer or they don't see an easy answer, they just tell us that there's nothing wrong. And when I finally had these new symptoms that, were clearly not in my head, depression does not make your ankles swell up so that you can't put your shoes on. I finally had somebody who said, okay, yes, something is wrong. And then I spent another 4 years of rotating diagnoses. Maybe it's lupus. No, I don't think it is. Maybe it's RA. No, I don't think it is. And we went through so many different diagnoses. And then we came up with sarcoidosis. And again, this is a rare disease. It's not something I would expect people to find right off the bat. But then because it's a rare disease that can affect so many different organs and systems throughout the body, it really needed to be addressed or examined kind of top to bottom. But most of the doctors that I had were not familiar with sarcoidosis. And as a result, if there was a new symptom that I said, I have this problem, they said, oh, well, it's probably the sarcoidosis. Or if I said, I have, do you think this might be? They said, no, I don't think it is. And they'd kind of just brush it off without any further examination, because they didn't understand what sarcoidosis was. So they also didn't understand what was and what wasn't. And that's where I, had a lot of trouble getting answers. And this rheumatologist who I see now, she understands sarcoidosis, and she's able to see which things fall under that category, which things fall under other autoimmune arthritis categories, which things fall under a different specialist purview. And so I really have that well-rounded approach, which I really, really needed. And so many of us do.
Got it. All right. I'm going to turn it over here to Lisa in a minute to comment on this, because we want to hear a little bit about your experience. We know that there are a lot of times, I'm sure, where people come in and they're not ticking all the boxes. And for us as patients, there often will feel dismissed or not heard. And I know, Lisa, you and I talked about several articles that have come out recently in the last year. I know there was one that was highlighted quite often at EULAR 2022 conference that was on this idea of being dismissed and what that does to break down, or a breakdown of communication and trust, and how that can even impact healthcare. So I just thought it would be a good opportunity just to weigh in on, that's got to happen to you, right? As a doctor, people come in, they're not ticking the boxes, their labs look great, but what do we do? How do you handle that as a rheumatologist?
Yeah, so I think the first thing is that I explained that rheumatology is like art appreciation. And so, because for our diseases, there's very rarely is there one test that is going to definitively say, yes, this is what you have. As opposed to other medical conditions, like hyperlipidemia, your cholesterol is either high or it's not, or diabetes, your sugar is either high or it's not. And we really don't have things like that in rheumatology. Instead, it's very much a clinical specialty where we listen to patients, we hear their symptoms, and then it's up to the doctor to interpret the labs and the diagnostic studies in the context of those symptoms. And because of that, it is imperfect. There's a couple of themes that I'd like to capitalize on that Carrie just shared.
Yes.
And the first is this concept of non-specific symptoms and then being told, oh, you're depressed. It's all in your head kind of thing. So autoimmune conditions, they develop over time. And we know that some people, they get all the symptoms all at once. And it's very obvious, like you come in with the rash and the joint pain and all the other things, like boom, we can diagnose that because you fit kind of what we call an illness script. You fit the description of what a condition looks like, which is what we're trying to do as rheumatologists, match patient symptoms to what these conditions sound like and look like in real life. But for those patients who don't have that boom, all of a sudden everything all at once, and instead they kind of have this gradual progression of accruing non-specific symptoms over time, it can be really challenging because there are many, many people in the world that have similar symptoms that don't have an autoimmune disease. And we don't want to misdiagnose somebody and put them on medications that can cause a lot of harm, especially nowadays in a pandemic. And more so, as I'm sure everybody listening to this podcast is familiar with, our immunosuppression doesn't really help fatigue all that much, and it doesn't really help the non-specific symptoms all that much. It's very frustrating. So usually how I explain it to patients is that, like at this point in time, I don't think you, so two things there, at this point in time, and then I don't think, everything's hedged. So I don't think you have an autoimmune disease, but something can always develop in the future. And so if something more develops, please come back and we will repeat the assessment, because that's the best I can do at that point in time. And I don't know how other physicians do it, have that conversation, but the hope is really by saying just that simple sentence and kind of setting the stage in that way, validating that you are having these symptoms, explaining that they're non-specific, they don't necessarily fit any one disease, and that things can progress, and my door's always open, come on back whenever something else happens.
When I got diagnosed, it took forever to get a diagnosis. Finally, I was heard. So the first doctor told me the words that I'll never forget: I'm going to wait and watch you get worse. And I have heard people say that recently. And I've actually heard that in conferences. I've heard presenters say, well, we need to watch and see how it worsens, but that's saying the same thing. So my first tip, if you're a doctor, rheumatologist, anything, be careful how you phrase that sentence because that, I'll never forget it. I feel like I'm permanently just stained in my brain of that time. I felt helpless. I felt like, oh my gosh, you mean this is going to get worse? And it's a very, very tough thing to say to somebody. So that was my first negative experience of realizing, wow, I don't know what's going to happen to me, and what does this mean for my longevity, my livelihood, all of that thing. And then the moving part, when I finally did get someone to diagnose me with something and treat me, and I started feeling much better, only to find out when I moved, because I was really in a good shape on a biologic and it had complete continuity of care. I wasn't sitting slumped over in a chair. I wasn't sleeping 16 hours a day. I wasn't waking up in the middle of the night in terrible pain and unable to move, because I was on continuity of care. I had the right treatment. And they looked at me and said, well, your blood work is great. I don't see any radiographic damage. Cannot justify you being on this medication. So they took away my diagnosis and took me off, or denied my treatment renewal. And that's how I found Al Kim. But anyway, so that's just one example of, and that happens. I wanted to point that out too, because I want people out there to know these kind of things happen to everyone, all different walks of people. You might think, oh, well, Tiffany, you're experienced in all of this. Well, it doesn't matter. But what I am grateful for is I knew enough to walk away. I knew it wasn't the right relationship. I wasn't getting what I needed. And I found a doctor who listened to me and who put me back on medication, thankfully, and put me on my way. So, Lisa, I'm going to turn it over to you and ask you about sharing a story, something that could go in this ebook that we're creating.
So I'm going to share a good story. I'd like to end on a positive note. So I saw a patient who was having non-specific symptoms: fatigue, alternating diarrhea and constipation, brain fog, problem sleeping, probably things that a lot of us could relate to. And she was referred to see me because one of her tests, the anti-nuclear antibody, or ANA for short, was a little bit positive, not a ton. And we did a whole history and physical exam, did a whole slew of lab work. And at the end, at that point in time, I did not think that her ANA was indicative of an autoimmune condition. And I didn't think that her symptoms represented an autoimmune condition at that time. And she had had some other aspects in her history that pointed maybe towards a diagnosis of fibromyalgia. And so the best part about this encounter was that she was so open to just listening and like letting me lay out all of my reasoning, and take it in for whatever it was that I was offering her. And I was like, as many people that were listening know, fibromyalgia has a terrible stigma associated with it. And I said, I'm not going to even put this in your chart because I don't want that to follow you. And if some people are going to try and make you feel like this is a problem in your head. This is not a problem in your head. We just don't know what causes it. And if we did know what caused it, we would have a treatment for it. And so, but there are things you can do. And this is, kind of like physical therapy and other stuff. And I've given this, I've laid out that framework so often, and not very many patients respond in a similar way, but she was just like so grateful for a possible explanation, and asked appropriate questions afterwards, and just wanted to make sure that she was on the right path moving forward. That in the end, it was a really wonderful experience, because I felt like it was a bi-directional exchange. Like she was telling me her story, I was kind of trying to put the pieces together, and then an opportunity for questions back and forth. And we both left that encounter feeling like satisfied with what had happened.